All right. Good morning, everyone. My name is Erin Braun, and I am a program coordinator for Western New York Rural Area Health Education Center. We're a nonprofit over in Warsaw, New York, and our goal is health education for our rural communities. Thank you for joining in this week for our second webinar. So the goal of our Choosing Hope webinars is to bring opioid and substance use disorder education and awareness, the stigma that comes along with addiction, as well as treatment and recovery options. We will be continuing this webinar series throughout April, every week on Tuesdays from 12 p.m. to 1 p.m. During this session, I ask you to remain on mute until the end of the end of the session, and then you can unmute to ask questions, or you can use the chat box as well. Just remember that everyone can see your questions in the chat box. You can direct your question to a specific person if you open up your chat and look at the drop down. You're able to change to the specific person, or you're able to open up your question to everyone. Or if you use your Q&A in the toolbar, that will open up the question to the panelists here. So myself and Karl, but not to our attendees. So for today, we have speaking Karl Shallowhorn of Buffalo, New York. He's going to talk about how providers can help individuals with co-occurring disorders develop healthy relationships with family, friends, and coworkers, as well as how community members can gain a better understanding of how these disorders can be overcome with support. Karl is a New York State certified alcohol and substance abuse counselor with over 20 years of experience in behavioral health. He currently serves as the director of youth programs at Mental Health Advocates of Western New York and is the president and founder of Shallowhorn Consulting. Karl is also the chair of Affiliate Relations Board of Directors of the Mental Health Association in New York State. Karl is also a host of a YouTube podcast called Mental Health Versus, and was a featured speaker at TEDx Buffalo 2021. So I'm going to pass it over to Karl next.
Thank you, Erin. And I just want to say real quick, there was a chat message, I don't know if you saw it, from John about the interpreter. He couldn't see the interpreter, so I'm not sure if you can hopefully take care of that for him. So I'm going to share my screen to begin. So as you see in the title, I call this co-occurring disorders, the chicken or the egg. And I want to, of course, thank Erin for inviting me to speak with you all today and welcome you to this program. And hopefully you'll get a chance to learn some things about mental health disorders and co-occurring disorders and substance use disorders, so that you can use it in terms of just understanding the ways that you can help someone in your life. You might be a provider yourself. Some of these things may be things you may already know, but hopefully I can add some information that will benefit you in some kind of a way. So real briefly, the reason why I'm calling this the chicken or the egg is that when you think about it, we don't always know which comes first. And sometimes, I'll give you an example, myself. So I live with a co-occurring disorder. I have bipolar disorder type 1, and I also have a co-occurring addiction disorder, cannabis use disorder and alcohol use disorder. And I developed this problem with my mental health, my bipolar disorder, when I was a student in college. And I drank before that, but then again, it wasn't to the point of dependence. So really, it's kind of hard to determine for me which really came first, in terms of just, was it the addiction that came first, or was it the mental health challenges that came first in terms of my bipolar disorder? So a lot of people struggle with understanding where it comes from. The bottom line is, however, there is help available for people. And I'm going to talk more towards the end about treatments that are available. So real briefly, I'm just going to cover some of the common substances that we know of. And of course, these are things that I'm sure you've all heard of. Alcohol, marijuana. There's also synthetic marijuana, which is on the market. In fact, you can find these at some stores, and actually they can cause very serious active effects in terms of how a person behaves and thinks. There's also stimulants, as you see here. The last one, cat, you may or may not have heard of. It's made from the leaves and twigs of the evergreen bush, interesting enough. So, but it does, all these are stimulants, and they essentially engage the nervous system and the central nervous system and the heart, and they really produce excess energy in many ways. Club drugs, of course, these are the kind of things that many times people use when they're going out and to clubs. And as you see, there's a number of them here, but they're all used to accentuate the experience of being with people and being out and dancing and all the things that go with it. Certainly, there are many young people that use these things, and even older folks that use these things going into clubs for years. And it's been found by many that for them, like I said, it makes that experience better for them. However, we know that many times these things can go south or in a bad direction, and a person might have a negative effect or bad side effects. One thing about these substances is that you can't really overdose on them and die per se, but you can have an adverse effect where it can affect you mentally and emotionally, certainly to the point of developing perhaps even psychosis or other conditions as a result. And then opioids are certainly one of the focuses I know of this series. Oxycodone, morphine, fentanyl are the prescription opioids, but also heroin obviously is something. And then methadone and buprenorphine is what is used oftentimes for the treatment of substance use and opioid disorders, where someone will receive methadone or buprenorphine in terms of just getting a way to perform, as we call it, harm reduction, to help them to mitigate the symptoms associated with these opioid disorders. There's also dissociative drugs, and dissociative drugs distort the user perception of sight and sound and create feelings of detachment. So they're technically not hallucinogens in many ways. However, they technically don't produce hallucinations, I should say, but they do have sort of like this psychoactive effect, and also, like I said, alter the person's sight and sounds and create the feelings of detachment. Hallucinogens, however, do cause these hallucinations, LSD, mushrooms, mescaline, for instance, and these are often taken to alter one's sense of perception and reality in many ways. And of course, these drugs have been used for decades and are still used today. And lastly, inhalants are the things that persons will inhale. One term that they use is called huffing. So some people will inhale would be gasoline fumes, or even, I know some people will use the substances that are found in window cleaner for screens of computers, those types of things, or also other poppers or amyl nitrate is another type of inhalant that produces like a rush of that person, that it basically gets the heart rate going and really produces this euphoric effect with inhalants. So when you talk about the criteria for substance use disorders, the DSM-5 is the Diagnostic Statistical Manual for all mental health disorders. And so essentially you talk about the criteria for substance use disorders. Really what you're looking for, these are the things that we use to determine if a person does in fact have a substance use disorder. So taking the substance in larger amounts or longer than you mean to. Wanting to cut down or stop using, but not managing to. Certainly not managing to do the work or school because of substance use. Using even when it causes problems. And then also giving up important social, occupational, recreational activities. And then the idea of needing more of that substance to get the effect that you want is called tolerance. And tolerance is a key indicator of a substance disorder, because as I would describe it, you might have someone that would begin, say, for instance, starting off with using or drinking, say, 1 or 2, bottles or cans of beer. and they would receive an effect of being buzzed or intoxicated. But over time, it'll take them more to get that same effect. They might eventually need 4, 5, 6 of that same drink or substance to get that same effect. That's what we call tolerance. And then lastly, you see there the idea of withdrawal symptoms, and they can also be relieved by taking more of the substance. However, in some cases, withdrawal symptoms can be deadly. In fact, in case of severe alcohol withdrawal, there's a thing called delirium tremens, which or otherwise known as DTs, which can cause someone to have severe withdrawal, and they could perhaps die from DTs. So as we know, in the severity of substance disorders, we have them categorized as being mild, moderate, and severe. And you see here we have the number of symptoms that basically categorizes these conditions as being mild, moderate, severe, 2 to 3 being mild, 4 or 5 being moderate, and 6 or more being severe. And actually these criteria, mild, moderate, and severe, apply to basically all of the mental health disorders you'll find in the DSM. You could have, for instance, we're going to talk more about anxiety and so forth as we go forward, but you could have a mild anxiety disorder or a severe anxiety disorder based on how many of the symptoms and criteria that you meet. So, as I said, anxiety, depression, bipolar disorder, schizophrenia, schizoaffective disorder, borderline personality disorder, these are relatively common in nature, the ones that we hear about the most. In many ways, also eating disorders are another mental health disorder, but these are ones I'm going to focus on today for this presentation. So first of all, I want to talk about anxiety. So it's that mind-body's reaction to stressful, dangerous, or unfamiliar situations. And essentially, it's the idea of unease, distress, or dread. As I often describe, anxiety is that we all experience anxiety from time to time. It's the kind of thing that keeps us on our toes, keeps us alert. Anxiety is something that engages us in that idea of fight, flight, or freeze type of mode. It was something that basically is innate in us in terms of how we relate to danger, like you see here. And so when we are experiencing anxiety, certain things happen. We experience certain symptoms, which I'm going to talk about in a second. But as I said, we all experience anxiety. However, it may not be an anxiety disorder. The example I give is that I remember my first date. When I had my first date, it was the kind of thing where I was a blind date, and the girl I dated, it was very awkward, and we went on this roller skating date. I'm kind of dating myself here, but we went on this roller skating date and holding hands. And I was very nervous, of course, very anxious, but it didn't cause me to not do my work at home or my work at school. It didn't affect my relationships. Those are things we often look at when we talk about a mental health disorder. So essentially, I experienced anxiety, but it was typical anxiety. It wasn't anything that just basically caused an impact on my life. So there are several different types of general anxiety disorders. Generalized anxiety disorder is a general sense of worry that can't be placed on anything specific. Panic disorder is really more along the lines of having panic attacks or anxiety attacks on a more regular basis. Oftentimes, there may not even be a trigger for these anxiety attacks. They can happen out of the blue. Social anxiety is when a person might be, for instance, having difficulty in social situations. They might have difficulty being in groups and so forth. Agoraphobia is fear of outside spaces. And obsessive compulsive disorder is essentially ritualistic in nature, where a person may count, they may clean, they may put things in a certain position, they may check things like the locks on the doors or the stove to make sure it's turned off. But essentially, it's a compulsive behavior based on a thought that they can't basically let go of, which can cause a severe effect on their life. One example of that is that when I've seen, heard of examples where people have had appointments to go to therapy, and they have actually not been able to make it in time because they kept checking the lock on the door and ended up being late. And so think about that. They need help, they want help, but unfortunately weren't able to get to where they needed to be because of the fact that they were so caught up in this obsession and compulsion and this disorder that has affected their life. So when you think about a sign and a symptom, a sign is something that you see, a symptom is something that you feel. So you see here, these are various signs and symptoms of anxiety. One thing to consider is that, as you see here, feeling nervousness, restless, tense, impending danger, panic, or doom, those are things that you necessarily can't see. You can't see an increased heart rate, but you can see hyperventilation, which is a sign, sweating, trembling. So these things you can see. Also feeling weak or tired, trouble concentrating or thinking, those might be more symptoms. Trouble sleeping could be a symptom. Difficulty controlling worry. So these are all things that could be associated with anxiety. But remember, like I said before, depending on how many of these symptoms and signs you have, depends on if it's a mild, moderate, or severe case. Depression, however, is a mood disorder that many times does go along with anxiety, but it involves that persistent feeling of sadness or loss of interest in things that one would typically enjoy. So it does reflect things differently than the typical mood fluctuation that someone would have in their regular part of life. One thing we know about depression is that, as I said, like even with anxiety, we've all felt sad from time to time, but it's when these feelings go on for more than 2 weeks or so. We typically say, if you're experiencing feelings of sadness and depression or even anxiety for more than 2 weeks, you should seek professional help. And this is where, we talked about the idea of family members and friends getting involved and helping their loved ones. These are the things to observe. If you see a loved one experiencing these symptoms and signs I'm talking about, then certainly reach out to them, try to guide them to get that help that they might need. Signs, symptoms of depression, that idea of a depressed mood, as I said, reduced interest or pleasure in activities once enjoyed, change in appetite, certainly sleeping too much or too little, slow movement of speech, fatigue is a big one, loss of energy. And the thing I want to say too about depression is that you might have someone, for instance, that's showing these signs of just sluggishness or not being able to be active. It's really easier to say to them, oh, just get up and just go for a walk, or why don't you just go exercise? Well, it's physically hard and not impossible. I know even in my experience many years ago, when I was experiencing a depressive period after a manic episode, I couldn't function hardly at all for quite a while. It was really very disabling, the depression I experienced. That last bullet point there, you see the recurrent thoughts of death or suicide or an attempt at suicide is something that oftentimes it comes at the end where basically someone feels no other reason to live. And that does happen. And so we know that in those cases, we have to be able to talk to someone and find out how they're feeling and try to guide them to their appropriate resources. Bipolar disorder, like I said before, is something that I have. I live with bipolar disorder type 1. And so that is basically where you have a person who experiences mania, which is this feeling of feeling high or manic or elevated mood. I'm going to talk more about what those symptoms are, followed by a period of depression. So that mania might be 2 to 3 weeks, followed by a depression, which might be certainly 1 to 3 months even. Bipolar disorder 2 is basically where someone might be experiencing, we call it hypomania, and the depressive periods might be more significant, and the mania they experience may not be to the level that someone would experience that is a full-blown mania. So the symptoms aren't as severe. And cyclothymic disorder is when a person might be experiencing these fluctuations, the mania and the depression, within a number of days. In other words, kind of like almost like a roller coaster of mood in terms of the mania and the depression, which can be very difficult to manage. So when you look at the symptoms in terms of the mania, abnormally upbeat, jumpy, or wired, certainly increased activity, energy, or agitation is something that happens. The one on the bottom there, you see decreased need for sleep is a big one for people who have bipolar disorder. I know even for myself, even though my last manic episode was in 1995. I've been very fortunate to have help in terms of treatment and providers and therapists and psychiatrists and family support. So I've been able to kind of learn what it takes for me to stay healthy. However, I still from time to time have this problem with sleep. So, but I've learned the tools I need to stay on track. I know, for instance, I had an experience about maybe 5 or 6 weeks ago, maybe about 6 weeks ago, where I was struggling for a few nights to sleep. The first thing I did was I called my psychiatrist's office, and he immediately intervened, and we had a treatment plan in place to work with my medication temporarily. That put me back on track, and I was back to my typical self within actually just a few days. So knowing what to do in that moment, if you have someone in your life that's struggling, that early intervention is key. If they're feeling like they are struggling, you definitely want to get them that help. Unusual talkativeness, racing thoughts, distractibility, and certainly poor decision-making, like going on spending sprees or taking sexual risk or making foolish investments. Those are certainly symptoms of mania. And then in terms of the major depressive disorder, these are pretty much the same that you would see in terms of depression. So they're pretty much the same that you would find that I talked about before. So there's really not a lot of difference there when you talk about the depressive symptoms of bipolar disorder as you would find in depression. Psychosis is something that is really very much misunderstood. So we really know, though, it's when that person has lost contact with reality. And they may have severe disturbances, as you see here, in thinking, emotion, behavior. So they're not as common. In fact, people with psychosis might be maybe 2 to 3% of our population. I know, for instance, people living with schizophrenia are approximately 1% of our population. People living with bipolar disorder might be 3% of our population. Not everybody who has bipolar disorder has psychosis. Some people do. I had bipolar disorder with psychotic features when I was ill. So that was something I dealt with, but not everybody does. Psychosis usually occurs, you see here, in episodes, and isn't a constant or static condition. In other words, for most people who live with psychosis, it isn't all the time. It kind of ebbs and flows. When I worked in a clinical setting, I worked at a local agency, Horizon Health Services, in a program for people with severe mental illness. And many of them lived with schizophrenia or bipolar disorder, but especially those living with schizophrenia who did experience psychosis, it wasn't all the time. In fact, if anything, they received treatment, they received medication, and were able to stabilize their condition so that really wasn't affecting them as severely as it would otherwise. And when it did happen, it was temporary and didn't happen consistently and constantly. So we talk about when psychosis is developing, and this is when it begins. These are called prodromal symptoms. These are the beginning symptoms of psychosis that you would notice. So changes in emotion or motivation, depression, anxiety. Suspiciousness is a big one, like being paranoid, blunted, flat, or inappropriate emotion. These are the things that you want to look for someone if they are beginning to exhibit things that might be unusual. One thing we know is that the typical age of onset for individuals that experience psychosis, whether it be through bipolar disorder, schizophrenia, is anywhere from, say, 16 or 17 to even 28, 29, maybe 30 years old. Bipolar disorder typically is between 17 and 25, and then schizophrenia, maybe 17 to 30, in that range, is when most of these cases occur. In other words, in young adulthood. And that's something to recognize too, because if you do provide an intervention early, that person is more likely to have a successful outcome with their treatment and their recovery. So in terms of common symptoms, there's difficulties with concentration or attention, odd ideas. There might be unusual perceptual experiences. And then, of course, you have the change in behavior, sleep disturbances, and so forth. And so really, these are the things that happen to someone that's experiencing psychosis, so that essentially what happens is they aren't able to function as they typically would or as others would. And there's a lot of reasons that, or a lot of things rather, that make people afraid of individuals who have psychosis because they don't understand it. And that's something to think about too, when you consider psychosis is something that is oftentimes best managed with medication. And that's where it can be difficult. And I'm going to talk about medication a little bit later. So these are the conditions which psychosis can occur: schizophrenia, bipolar disorder, psychotic depression, schizoaffective disorder, and drug-induced psychosis. So schizophrenia is that serious mental illness that affects how a person thinks, feels, and behaves, and they may have lost touch with reality. So here are the characteristics of schizophrenia. Delusions are these beliefs that aren't grounded in reality. So you might have someone who believes that they have superhuman powers, or they can tap into things that are not, coming through the computer, or they're getting special messages from somewhere. Hallucinations are these perceptual experiences of seeing things, hearing things, even smelling things that aren't there, and so forth. Loss of drive, blunted emotions, and social withdrawal. Schizoaffective disorder is a combination of schizophrenia symptoms, but also a mood disorder, such as depression or mania. There's also a bipolar type of schizoaffective disorder. So we know that with schizoaffective disorder, it can be very difficult to treat, because of the fact that you're trying to treat, in many ways, two different conditions: the psychosis, the schizophrenia symptoms, as well as those of the mood disorder. I want to talk briefly about borderline personality disorder, which is also another condition that what many people don't understand, and who also can be at times difficult to treat. So it really involves more about regulating emotions, controlling behavior, remaining stable, and maintaining stable relationships. So people who have a borderline personality disorder oftentimes have difficulties with the relationships that many times will separate them from others, and essentially make it difficult for them to form long-lasting relationships. So, in fact, look at here, see some of the symptoms: a pattern of intense and unstable relationships, distorted and unstable self-image, impulsive and often dangerous behaviors. With someone with borderline personality disorder, I remember I had an experience when I was working, once again, that same clinical setting that I talked about before. One of the things we noticed was the individual that had this condition, was living with this condition, would split. In other words, they would say one thing to one person and something to someone else, and almost get the two people thinking two different things to get kind of what they wanted, or get to manipulate others. And that's a common thing that sometimes people with borderline personality disorder may do in terms of that splitting behavior. Recurring thoughts of suicidal thoughts, behaviors or threats, chronic feelings of emptiness, and so forth. Feeling of disassociation, such as feeling cut off from oneself. So dissociative thoughts are when you feel detached, once again, from yourself. Briefly, trauma is something that I wanted to mention, is because trauma is something that actually is found to be a risk factor and contributes to probably about 80%, research shows, of all mental health and substance use conditions. So trauma is significant in that, as you see here, it's a series of events, set of circumstances, but really it's something that can truly alter a person's life in a moment. I want to give another real world example. Think about currently what's going on with the war in Ukraine. The people that have had to flee their homes, that are experiencing the bombing, that are experiencing the loss of life, loss of family, the trauma is incomprehensible. Imagine if you're one of those people experiencing all that they've gone through and they're going through. Sometimes we see the news reports. They're hard to watch. That's where some people can even experience vicarious trauma or secondary trauma just by watching other people's experiences of trauma. But trauma is something that's very significant and can be long lasting. So here's some examples of trauma. Physical abuse, certainly sexual abuse, we've heard about those a lot, but also domestic violence can be experienced as trauma. Community violence, medical trauma, in terms of it could be the experience of getting a diagnosis of, say, cancer or another critical illness. Terrorism, refugee experience. Like I said, look at those who are fleeing their war-torn country of Ukraine. Natural disasters, we hear more and more about hurricanes and so forth that cause trauma as well. Earthquakes, and then serious accidental injury. So all these are examples of trauma. neglect, and so forth, impaired caregiver, forced separation, war, trafficking, and also seeing a suicide. So these are all things that can produce an experience that can result in a person developing a mental health or substance use disorder. PTSD is the main form of trauma-related effect that we know of, life-threatening and so forth. They re-experience this traumatic event in some kind of way. There may be some kind of avoidance behavior that goes with it. So with people who have PTSD, they try not to re-experience that trauma. That's why when you treat someone for trauma, you don't want to re-trigger that experience for them. Some signs and symptoms real briefly: intrusive memories, traumatic events that are happening again, nightmares, severe emotional distress, avoidance, avoiding places, activities, or people that remind you of the traumatic event. As you see here, I also have acute stress disorder. Acute stress disorder is basically the same as PTSD, but it's only, the symptoms only last for about a month and then will dissipate. PTSD is longer lasting, like I said. So let's talk about co-occurring disorders. So co-occurring disorders, otherwise known as dual diagnosis. Here's some statistics. As you see here, adults with mental health and substance disorders are twice as likely to have income less than 150% as adults without either disorder. So what does this say? So basically, we know that people with co-occurring disorders tend to perhaps live maybe more in poverty or have lower incomes. Over 8.9 million people have co-occurring disorders, and that's what's reported. It's interesting that when you look at statistics, when you talk about mental health and substance disorders, those are the numbers that are reported. There are a lot of people that these things don't get reported. So there's always more, I believe, than what we see in this research. Depression and anxiety exists in 20 to 50% of people with alcoholism, cocaine, and other stimulant disorders. So as you see here, once again, a lot of people that live with depression and anxiety also have a substance use disorder that goes with it. Only 7.4% of individuals with both disorders receive treatment, and 55.8% people don't receive any treatment at all. That is a very significant number when you consider that there are a lot of people out there who have co-occurring disorders that need help that aren't getting it. And that's why I think it's so critical that we as providers, but also as family, friends, and even coworkers or neighbors or whoever, if you identify someone that might be struggling, that we try to get them to the appropriate resources that are available in your community. And then also 24% of Medicaid recipients had psychiatric conditions, cardiovascular disease, and other central nervous disorders. So also you talk about co-occurring disorders and co-occurring conditions. There also might be medical conditions involved with it as well. Women more at risk of anxiety, depression, anxiety, and substance disorders and history of trauma. So once again, these co-occurring disorders happen more because of trauma. And I said before, trauma is a major risk factor when you talk about these things. And then here's some of the common combinations with drug and alcohol and addiction or substances and mental health disorders. Schizophrenia and schizoaffective disorder, mood disorders, trauma, and then axis 2 disorders, of which borderline personality disorder, narcissistic, antisocial, histrionic, dependent, and avoidant. Those axis 2 disorders are called personality disorders. And they're not the same as, say, as we see here, schizophrenia, depression, major depressive disorder. They're a different category in the DSM, the Diagnostic Statistical Manual, and they are more behavioral in nature. The treatment for those types of disorders is different than you would find for schizophrenia. They oftentimes will not use medication. They tend to use more talk therapies or therapeutic therapies in terms of like dialectical behavioral therapy, for instance, is a big one for people who have borderline personality disorder, rather. You would use that treatment for individuals that experience that. So why do these substances co-occur? Well, one reason we know is that many people will self-medicate. You might be experiencing depression, so you'll use something to bring you out of that depression. a stimulant. For instance, you might be depressed, you might use amphetamines, or you might even use cocaine or something like that. Or you might be anxious. Many people who experience anxiety are using cannabis. That is probably one of the most common that I've heard about, and also alcohol, obviously, too. But cannabis is the one that I'm hearing more and more about recently. Instead of using prescribed medications, people are using cannabis. And now with this legalization in New York State, even more so, I think people will be using cannabis to self-medicate when they experience anxiety, which can be dangerous if the person is having severe effects of anxiety that perhaps might be better served by seeing a professional. The causal effects, as I said, in my case, the interesting story for me is I'm adopted, and I learned much later in my life, only about 5 years or so ago, I learned about my birth family. And it turns out my birth mother lived with serious mental illness. My adopted parents I lived with, grew up with, obviously, didn't have any mental illness. My father drank heavily. But I believe that much of my mental health conditions was due to the substance I used when I was in college. I began to use drugs more. Also, there was significant stress. Stress is also a risk factor in terms of mental illness as well. And we know that for a fact. Common correlated causes, the risk factors that give rise to substance use or mental illness can overlap. So things like trauma, as I mentioned before, can be correlated to substance use disorders as well as mental health disorders. Now, when it comes to treatment, there are a lot of ways to treat co-occurring disorders. However, one of the ones that's come about, let's say in the last maybe 15 years or so, that's become more prominent is what we call integrated treatment. The idea with integrated treatment is that you are really treating that individual with, say, one provider, one treatment team. In many cases, individuals will go to programs and they'll receive their mental health treatment with one therapist and their substance use treatment with another therapist. Now, it's become more of an outmoded form of treatment. Back when I was receiving treatment many years ago, that's kind of how it was done. Now you'll find many agencies, they will have people who will receive both, the mental health and the substance use treatment in one setting, in one set of providers. So basically, medication therapy is often used for individuals when addressing both. And in co-occurring disorders treatment, the traditional hesitations about prescribing psychotherapeutic medications are no longer an issue. One thing that happened in the past was, before, years ago, when it came to treating someone with a substance use condition, there used to be concern about treating them with medications because of the fact there was thought there could be dependence or other issues. Well, that idea has gone by the wayside in many cases, and we realize that by using medications, we can treat, say, the mental health condition, which would then alleviate some of the problems with, say, the addiction of the substance use condition. So treating that person in the same way, with the same tools, can be really more effective than treating them, individually. Group therapy is also something that would be very helpful. The thing that's great about group therapy is that you have a number of individuals, usually facilitated, the group is facilitated by one or two therapists, and the group really does the work. You might get one member of the group who might be experiencing some success with things that they're doing, and might be able to be an example for others as to how they're using this as a means of getting healthier, developing that pattern of recovery. And so it ends up being almost like a support network that people can use to help each other. This is also found in 12-step programs. I'm a member of a 12-step program myself. I belong to Narcotics Anonymous. I've been a member for 34 years. And even though it's not group therapy, there's still this idea of support, mutual support, group support, which I found has been instrumental for me, maintaining both my mental health and as well as staying clean from substances. So as you see here, treating addiction and a mental health disorder at the same time helps rehab clients address their unique relapse triggers such as depression, mood swings, or panic attacks. So when individuals go to rehab and are able to get both things treated this way, it helps them with the overall well-being. There's one clinic in Bradford, Pennsylvania, called Bradford. I think it's called the Bradford Recovery Center, I believe. But they basically help individuals with dual disorders and co-occurring disorders. So that is one inpatient program that specializes in co-occurring disorders in a way that really helps people that might be dealing with both things that may have not had success in other settings. So one thing that you see here, as far as one of the primary objectives, is to have staff members who do have this specialized training and qualifications in co-occurring disorder treatment. So when you think about it, it takes a special skill set to know about substance disorders and mental health disorders. One thing that many providers offer now internally is training and education, professional development. And that's key and important in terms of clinicians staying on top of their skills and learning. But if you have individuals who know about both mental health and addiction, they can be much more effective with individuals, obviously, who might be dealing with these conditions. Now, also, we know that people with co-occurring disorders that might be going to substance treatment, we don't want to exclude them. We want to welcome them. And as I said before, this is happening more frequently now because we realize that just because a person has a psychiatric condition doesn't mean that they can't be responsive to many of the same treatments and tools that are used for other conditions. And then given that addictive disorder and the co-occurring psychiatric disorder, the same level of attention and care during the rehabilitation process, and addressing both the mental illness and the substance use disorders, chronic relapsing conditions that require long-term support. One thing that we also know is that co-occurring disorders require a lot of work to maintain in terms of long-term recovery. It takes a lot of effort to understand how one can relate to their triggers, how one can manage their mental health. So imagine if you're trying to understand how to handle your depression, but you also have the issue of trying to deal, say, with an alcohol use disorder, for instance, and trying to do both those at the same time. That can be very challenging because you're trying to almost juggle two disorders at the same time, concurrently. So if you're able to handle that and learn the tools, you can be successful. But it's about learning how to do those at the same time that can be challenging for many people. So we find that's why so many people do struggle with co-occurring disorders to maintain that sense of stability in their lives. So once again, like we have individuals that are trained, we also want to have treatment teams that are trained in addressing co-occurring disorders. Most agencies have this now and have the capacity to do this, larger agencies. Of course, here in the Buffalo area, we have Horizon, Best Self, Endeavor, Spectrum, Monsignor Carr, Brylin. Most of these larger programs have the staffing to do that. Some of the smaller agencies, maybe not so much, but the larger programs do. So we do know, and I said this before too, addressing these problems early is really the key. If you address a problem early, the outcome is going to be likely better. As with finding any other health condition, you might have someone who might develop diabetes or might even be pre-diabetic. If you address it early, they're less likely to go into a full-blown diabetic health challenge. Same thing with mental health and co-occurring disorders and addiction disorders. If you address it early, then they can have that process begun and they can recover in a much better fashion. And lastly, treating all clients with dignity and respect, even if they're in a medical crisis or acutely intoxicated. So this really comes down to how we treat individuals and how we look at them as people. One thing I want to just share too, when I had the experience of working at Horizon Health Services, which is the clinic that I worked in, the last clinical position I had with the clinic with the individuals with severe mental illness, some of whom did have co-occurring disorders. The one thing I really realized was I had a really profound sense of empathy for the clients that were there, because I'd been in their shoes. I'd been in that experience. I'd been in treatment. I'd been in outpatient therapy. I'd been in outpatient groups. I'd been in received public assistance and so forth. So I knew in many ways what they'd gone through. And so I was able to, despite what they're going through, treat them as I would want to be treated. And that's a key thing when we look at someone. So if you have a loved one in your life that's struggled with these things, put yourself in their shoes. Try to practice empathy. When you're with them, listen. And that's another thing too that you want to understand, is that when someone is struggling, sometimes they just want someone to listen to them. If you take the time to listen to them, they're more likely to respond in a way, say, for instance, that they may want to seek help. And that's important because we want to use those tools that are at our disposal to get them the help that they need. So listening is key. Also being willing to guide them to the proper resources. So we want to encourage them to seek help. We want to encourage them to find whatever resources are available in your community. And also now with the advent of telehealth, there's more available. And so telehealth is one of the things that's come out of the pandemic, which is actually a good thing. And so we know that telehealth is more available for people to help them have a better opportunity to experience treatment in different kind of ways. And then of course we have these different therapeutic options, residential programs like rehabs, outpatient programs, individual therapy. Medication is a big one. As I said, there's things like Suboxone, which is buprenorphine, methadone, certainly, but also medications for psychiatric conditions as well. And so those are big ones. Peer support groups like NA, AA, and so forth, but also education counseling for families. You talk about psychoeducation for families is really crucial, because if the families know more about what their loved one is dealing with, then they're more likely to understand and how to help that person. So community education is really vital when it comes to learning about how to help your loved one. Holistic therapies are things that might be more along the lines of things like exercise or understanding how to use relaxation techniques. A lot of these things you can find online using a meditation app. I use a meditation app every day that helps me a great deal. And then of course, the ongoing support after rehab is important, because we want to be able to let people know that even though they have been rehab, they need that follow-up. They need that warm handoff to a program that can help them, despite the fact that they received that 28 or so day support they experienced. Here's some brief resources that I want to just share. SAMHSA is a major resource. It has a lot of tools. The National Alliance on Mental Illness is a great family-based advocacy program that helps family members of loved ones with mental illness. Great resource, a lot of good information. And mentalhealth.gov and Mental Health America. Mental Health America is the parent organization of the Mental Health Association of New York State, of which I'm on the board. They have a great mental health screening tool on their website. So these are excellent resources that you can use to learn more about the topics I've discussed. And then also the Mental Health Technology Transfer Center Network, youth.gov, and then the Co-occurring Disorders Information Center. So if you just Google Co-occurring Disorders Information Center, it'll take you to this page, and what will happen is it'll actually guide you to one of the Mental Health Association New York State pages, which is operated to show the Co-occurring Disorders Information Center, which once again provides resources, information, where to find things that you would need to know about this topic. So with that, I think we have a little time left. We have about 10 minutes or so, I know. I think we want to just see if there's any questions. I'm going to stop sharing so we can perhaps see if there's any questions that come through. Erin?
Yeah, I did in the chat here. When you hear, I have a question from Christine. When you hear voices telling you to do something, asking if that's a psychosis.
Yes, so that's an auditory hallucination. Now, the thing to understand about auditory hallucinations is that's called a command hallucination. The thing to understand about a command hallucination is that they don't always happen that way. Many people who have auditory hallucinations might be responding to something that might be a friendly voice. I'll give an example of that. When I worked at that same clinic, I had a couple of clients, one client in particular, in a group setting would giggle, believe it or not. She would giggle, responding to this voice. So obviously it wasn't telling her to do anything, but I will say this too. One thing I didn't talk about this whole topic is stigma. And stigma is something that affects people living with mental health and addiction, and many times will skew or change people's perceptions about mental illness. So we have to be really careful when we look at individuals, because the numbers are so small. Like I said, 1% of our population lives with schizophrenia. That's 1 out of 100 people. And so it's not just everyone that you see that you might think that might be dealing with that. So, and like I said before, they're episodic. They don't happen all the time. So that's the answer I would give to those type of hallucinations.
If you have any other questions, you're welcome to unmute. You can ask Karl, or you can put it in the chat or the Q&A. The next question. So can someone have one episode and not have any other episodes?
Yes, absolutely. So that's the thing to remember, not to understand, not to remember, but to understand. Some people have one episode of psychosis and never have it again. And that's the thing to know, is that just because you have had this episode with the proper treatment and support, you never have to have it again. There's a program here in Erie County provided by Best South Behavioral Health and Erie County Medical Center's outpatient program. It's a first episode psychosis program, where if a person does experience a psychotic episode, they can receive treatment, intensive treatment through medication and therapy, so that they don't experience an episode again. And it's proven to be very effective. And we know with those proper supports, they can live a healthy and productive life.
Great. Does anyone else have any more questions? Any more questions? I would just like to comment. I really thought your emphasis on empathy was great. Listening. I'm interested. So you had mentioned you worked with Horizons Health Services. What other organizations are available in the Western New York community if someone thinks they're dealing with a disorder, if they're looking for help? What do you have suggested organizations to go to, or what is available? I know you had just mentioned one.
Sure. I know you're located in Warsaw. So I think one of the things I would recommend that people do, and I didn't give us a resource, I don't know why I didn't, where I work, the Mental Health Association of West New York, Mental Health Advocates of West New York. So that's, in fact, if you want to put in the chat, Aaron, it's MHAWNY.org. MHAWNY.org. And our telephone number is 716-886-1242. And we have resources and information where if you want to know where to get treatment, we have, this database, which is pretty amazing, of providers. So even though you might be in an outlying area, there are programs in outlying communities that are available. Like I know in the Southern Tier, in Derby and so forth, some of the hospital-based programs are out there, outpatient programs. But if you contact us, that's where you can find out more about where to get that help.
Great, thank you.
Sure.
If there's no other questions, we can wrap up. I just want to let you know that this was recorded. So if you want to see Karl again, or if you, for anyone that may have missed this, we are posting this on our website at Western New York Rural AHEC, and our website is, put it in the chat. Okay, so you can find it there if you're interested in viewing, or if you know anyone else that would be interested in viewing. Next week, we are on Tuesday at 12 p.m. We will be having New York Matters speak as concerning medicated assisted treatment, as well as Dawn Stone from Spectrum Health and Human Services regarding our Narcan training. If there's no other questions, we will say goodbye.
Thank you, everyone.
Bye. Have a good week.